So I am geeked out and excited this morning because I live in the policy space, I live in the legislative space, I live in finding solutions. So the fact that you're going to get to hear from three amazing psychiatrists who have been working in their different areas, talking with us about their knowledge of what is not going well currently in the mental health care system, that makes it much more challenging for all of you who are trying to help keep people in outpatient treatment, right, under court orders. We know that there's been a lot of challenging aspects because of all the policy and funding changes over the last 60 years, if not longer, right? So we know that certain things, like we've been talking about this morning, not having housing, a lack of state and acute care hospital beds, not enough treatment providers, all of these are really difficult. So today we're going to address some of these challenges, and our experts are going to share some thoughts about what we can all be doing to both help the folks that we're working with directly on a daily basis, but also how we might engage all of you in doing more work of how to fix the system overall. So to get us started, I'm going to ask each panelist to introduce yourself to our audience. And we're going to start here with Dr. Ingrid Schmedtje. I was worried about saying her name.
You did great. Good morning. Thank you so much to Leslie and to TAC for having me here today at the AOT Symposium. I'm an adult psychiatrist with 30 years of clinical practice in community mental health in southeastern Virginia. I've worked in outpatient services in the psych services clinic as medical director, and for the last 17 years of my medical career on our clinic's two-city ACT program that serves Chesapeake and Portsmouth, Virginia. From teenage years on, I hope to be a physician, specifically a pediatrician. I came to medical school via a detour through the humanities, studying literature and language. By the time I was writing my master's thesis on Freud, I should have realized I wasn't going to be a pediatrician. In my clinical rotations, I found what I really loved was listening to patients' stories, how they got sick, how they might get well, and patients love to tell their stories. So I would pull up a chair and listen. That's how psychiatry found me. Every patient has their own unique story, and our patients who experience serious mental illness have stories so difficult to fathom with the misunderstanding, the isolation, and the suffering that they experience. Making sense of their stories together, to me, is where humanity and medicine intersect, and where the treatment and healing can begin. Thank you.
And Dr. Mark Munetz.
Hi, I'm Mark Munetz. I'm a retired psychiatrist. I started out as a clinical psychiatrist in the community. I consider myself today an academic community psychiatrist. My focus has always been on trying to care for the most seriously mentally ill, the people in the greatest need. There are three things most proud of when I think about my career, because I'm 5 years out of it now, so I'm not in current practice. So I just get to brag about what I've done, and the really nice thing about being here, and I feel like I need to shout out to Dr. Gibson. Her presentation was amazing in the last hour. I was 20 years medical director for the Summit County Alcohol Drug Addiction Mental Health Services Board. It's the Akron area. It's where Judge Stormer is the probate court judge now, and Judge Stormer and I go a long way back together. But before Judge Stormer was at the probate court, there was another judge, and I was new to the county, initially at an agency that focused on seriously mentally ill folks, and then I got this job as the medical director for the county board. And I was aware of outpatient commitment, but I had practiced in Pennsylvania and Massachusetts before that, and we didn't do such things. But I came to Ohio, and the 1988 mental health law, as I read it, allowed for what today we call AOT. And so in 1992, I'm proud to say we started an outpatient commitment program. It was quite effective, and we had data to prove it. It's gotten better with a judge who's active and is improving the program. But I'm very proud of having started, helping to start AOT, and it's helping because it's all with the partnership, as has been said before. I'm also very proud of bringing CIT to Ohio. We were the first county in the state to have a crisis intervention team, and we got so excited about it that my law enforcement partner and I, along with the National Alliance of Mental Illness in Ohio, NAMI Ohio, and with a little bit of help from a justice of the Ohio Supreme Court, we just got lucky to connect with Justice Evelyn Stratton. We spread CIT throughout Ohio, and I believe we have the strongest CIT program in the country, with officers in all 88 counties and thousands of CIT officers. So I'm very proud of that. And that work led to the creation of a statewide center to promote work at the intersection of the criminal justice system and the mental health system, what we call the Criminal Justice Coordinating Center of Excellence at Northeast Ohio Medical University, where I became the chair of psychiatry. And in that work, my third thing to brag about is helping to co-develop the sequential intercept model, which I think has been impactful beyond my wildest dreams. My partner, Patty Griffin from the Gain Center, and Patty was a consultant to our county, and we said, well, maybe we can put some structure to try to get communities to think about in a systematic way how to keep people with serious mental illness out of the justice system. And we published a paper in 2006, and it's, how many of you have heard of the sequential intercept model? I appreciate that.
Thank you, Dr. Munetz.
So I'm going to stop, but I do want to say I'm retired, so I can say anything I want, and there's no danger to me.
And Dr. Cynthia Lewis.
Hi, good morning, everyone. My name is Cynthia Lewis. I'm a psychiatrist. I went to Howard University for undergraduate studies. I went to Meharry Medical College for my medical training. I did my psychiatric residency at Johns Hopkins. I had an obligation to the National Health Service Corps, which allowed me to work on the Eastern Shore of Maryland for my payback. I thought I was going to be a forensic psychiatrist, or maybe I loved eating disorders, but the payback forced me to go to an underserved community, which led me to become a community psychiatrist, which was probably the greatest thing that happened. So I, after my 3-year obligation, I went back to Hopkins, worked in our community psychiatry program for about 15 years, treated a lot of patients with chronic mental illness. We had a lot of wraparound services, social workers, nurses, psychiatrists, emergency department, inpatient unit. I think I took for granted how well these patients did despite their chronic mental illness because of just the wraparound services they received. Around 2010, I was asked to direct our emergency department from afar. We had residents who were in our emergency department as the workforce. I supervised them, did case present. They could call on me anytime. But I left Hopkins in 2015 to do all private practice. But I really missed, my chronic patients. I really realized that's where my passion was. In 2019, the hospital asked if I could come back to the emergency department and be embedded. And that's really what was my dream job. So I closed my private practice for the most part, came back in 2019, did 100% of my time in the emergency department, and that was when my eyes were opened. I realized in community psychiatry that we would lose about 10% maybe of our patients who were more disorganized, needed more services. They would go to ACT teams. In Maryland, we had capitation programs, but I didn't know until I was in the emergency department what was happening to the other patients who refused to engage with the ACT teams, who would not stay voluntarily for the capitation services. And I got very alarmed when I would see patients who were homeless now, being brought in from the police with emergency petitions. I would hospitalize them if they met criteria. A lot of times they would agree to come in voluntarily, only for me to see them a week later after they were discharged and were on their medicines while they were there, but now not on their medicines. That led to me being very concerned, reaching out to our insurance companies to understand I'm seeing this person 15 times a month. I'm a taxpayer here in Baltimore. What's going on here, and realizing that hundreds of thousands of dollars were being spent on just a failure. Fast forward, just for the sake of time, that led me on a crusade of what do we do? I did a grand rounds on do we need to rethink state hospitalization. It was during that research that I realized that Maryland was one of 3 states that didn't have AOT. I knew about Kendra's Law in New York, didn't realize that AOT was that, and I will say as a psychiatrist, it wasn't until being in the emergency department and community that I really realized that we need to be more concerned about this population. I got involved with our legislative committee, with our MPS. I met wonderful advocates like Deborah Bennett, who you all heard from yesterday. You know, I knew her son when he was alive, and when he was released from capitation, I could almost write what was going to happen. But Evelyn Burton, who I don't think is here today, I met her on the advocacy trail. After 3 years, Maryland had an AOT bill coming up in their legislative sessions for 20 years that were being opposed, and I didn't understand it, and I was really concerned, and I really made it my mission that I wasn't going to retire until Maryland had AOT. So Governor Westmore, he actually had, he had AOT on his platform, and his secretary, Herrera Scott, who I saw her in Annapolis during the legislative session that year, and said we really need AOT. I really think you all need to understand how important it is. And again, 2 years later, we were able to get it out of the House. I was the only psychiatrist who testified during giving written oral testimony, and I realized we are not at the table. We need more physicians to really, champion the cause. The following year, I was able to bring in a couple of other colleagues from the major institutions in Baltimore, and then that year was when it was passed. So again, still I direct our emergency psychiatric services at Johns Hopkins, and I love this patient population. July 2025 is when Maryland will start to roll it out somewhat, and where the data that was shown earlier, New York, that's what I would testify, like this is the data, like we're spending hundreds of thousands of dollars on failure, but people are saving millions if we just had, to me, a common sense approach. So that's my story.
Thank you. So each of you have practiced psychiatry for quite a few years and have certainly witnessed substantial changes over those years that really have adversely affected the ability to help these people, right? So I'm going to ask each of you to share what you think have been the most detrimental changes from your perspective. Go ahead.
Yeah, so we've been talking a lot about the broken system, and I really just see it even more as fractured and fragmented and splintered, where there are now so many interfaces where things can go wrong, where there's hurdles, there's logistical problems, there's information that's not transmitted. When I think about sort of what are the major problems that I've faced over the last years in outpatient psychiatry, I kind of think of the 4 C's. And that would be continuity and coordination of care, criminalization of mental illness, the corporate takeover of medicine, and the COVID-19 pandemic. So just to sort of where I started out, I completed my psychiatry residency in the early 90s at UMass Medical Center in Worcester, Mass. And it was really a community mental health forward program that I think at the time was ahead of its time. So here's what mental health treatment looked like back then. So the 8th floor of our large teaching hospital contained an inpatient psychiatric unit. Embedded in the emergency room department was a psychiatric emergency room, and we were the gatekeeper to our state hospital. The state hospital was literally a couple of hundred yards up the hill. And so transfer would involve a commitment order, orders, a detailed summary, and a phone call to the admitting house officer at the hospital outlining any additional concerns. There was a large affiliated outpatient clinic and a solid network of community mental health centers for outpatient care after discharge. So a lot of patients that were well known to us, they might just get treated in the psychiatric ED for recurring brief medical problems and just kept for a couple of hours or overnight and discharged back to the community. If patients were hospitalized, the hospitalizations would often be weeks or sometimes longer. And if the patients were not known to the system, we would carefully withdraw medications to see what we had diagnostically. So if anybody recognizes that as their current healthcare system, please raise your hands. Yeah, good, okay. So we have a couple, that's encouraging. It's certainly not what I've seen in my community. So in terms of, my first C here, continuity, there's just so little continuity of care for this population right now. There are so few inpatient psychiatric beds locally. The turnover is so rapid. If there is a bed, often just a couple of days. Our state hospitals are supposed to serve as a safety net, but usually there's a waiting list. So we've created this new treatment entity that is now called ED boarding, which probably Dr. Lewis can speak to much more eloquently, where basically patients are housed and boarded in the emergency room awaiting a state hospital bed. Now, in terms of once they get it accepted, it can be at any one of the 11 facilities in my state, Virginia. Some of these are 5 to 6 hour driving distance from where the patient's housed. So you can imagine what a maze and logistical nightmare discharge planning becomes. So in terms of and then of course, there's significant understaffing and staff turnover right now at most of the clinics. So just as an example, there's currently a 25% staff vacancy rate at the clinic that I used to work for, and that includes the position of the executive director. Almost all of our psychiatric services are now provided via telehealth, and there's a shift to nurse practitioners. A lot of our providers are located as far away as the West Coast, and they have no sense of what the communities are that they're trying to serve and the resources that are available. So we have talked a lot about my third point, the criminalization of mental illness. Without timely access to inpatient beds, when it's really necessary, especially our male patients, and even more so our male patients of color, wind up much more often in jail and prison, often for nuisance crimes. There, often treatment, both medical and for mental health needs, may not be readily available. The jail and prison formularies are often very limited, and only some of the most inexpensive drugs are available, so patients may get taken off of medications that previously worked for them and get switched to ones that have been previously ineffective. So according to the January 2024 TAC Prevention over punishment report, in Virginia, only 32% of all state hospital beds were filled by civil patients. So as forensic patients fill our state hospitals, our civil patients are shifted to the jails, which has become our default hospital system. In terms of my third point, the corporate takeover of healthcare. I mean, one of my favorite ones here, but I'll be brief about this. There's a huge paradigm shift right now in medicine, where medical care is being taken over by corporations and hedge funds. We are looking at what's called value-based care and RVUs and maximizing efficiency. So this means for us as providers, much less time with patients face-to-face, so we can see even more patients with whom we spend even less time. There are prior authorizations for care for many medications. We deal with pharmacy benefits managers who may dictate which medication treatments are available. And we can't treat patients well if we can't see them and listen to them. We are really taking the art out of the art of medicine. So the last point I want to talk about, which is really very near to my heart, and I think we can't really talk about where we're at right now without talking about the COVID-19 pandemic. So on March 16th, 2020, the day after the official pandemic lockdown, I arrived at our clinic to find the front and back doors locked with 24/7 security guards in place who monitored entry, temperature, and masking. And this would go on for a very long time. The halls echoed with emptiness. While every other service was shuttered, working remotely, the ACT team's presence in the community was imperative and non-negotiable. With fewer supports and resources than ever before, the task really became Sisyphean. COVID-19 accentuated and accelerated inherent inequities socially, politically, economically, in terms of healthcare and access exponentially in our most impoverished neighborhoods. With schools, workplaces, churches, libraries, rec centers all shuttered, there was no place for people to seek refuge other than maybe on the streets. Anxiety, depression, domestic and gun violence, substance use skyrocketed. The opioid epidemic was already in full swing. On May 25, 2020, George Floyd was murdered in Minneapolis. The pandemic had already set the stage for revisiting America's very real problem of systemic racism. The tension with law enforcement escalated. The same officers that are needed to transport patients for custody orders, civil commitments, and hospitals. There was fear and anger in our communities and on the streets.
Can we move on to Mark?
I just have one more paragraph.
Okay.
Okay. And where there's fear and anger, there will be violence, and violence begets more violence and collateral damage. In all of my years of practice, I've never experienced a more charged and volatile interface, and we haven't even begun to recover from the effects of that.
I don't have a whole lot to say more than what we just heard, but you know, it's like what she said. Yeah, I made some notes. We did know what the questions were going to be, in case you wondered. But I'm not as organized to write it all out. But I made some notes, and there are three things I thought I could talk about. And I think all three were basically just covered, but I'm going to come back to one. And it goes back to what we heard yesterday from Meg Kissinger. There's no system to the system. I arrived in Summit County in 1992. This is a long time ago. And I was hired by a man who was not necessarily well-liked, but he was brought in by the county to the board to run it, to make a system of the system. And that happened because a woman named Maggie Carroll Smith, who is long gone but not forgotten, was a NAMI mommy who said, we got to make a system out of this system. She used to go around saying, there's no system to the system. So, and at the end of probably 15 or 20 years, during a time when resources were high, largely because we were depopulating the state hospital and funds were flowing from the state to the county, we built a system that I was quite proud of. I thought, at one point, I thought we had the best system in Summit County, Ohio in the state, and we had people visiting from other states who said, this is the best we've seen, so we could brag we were the best in the country. And in the last 20 years, a lot of that has been lost. It's still probably better than most because we've got some things that I think are, I don't know what.
Just keep talking.
Feedback. Yeah, they're doing construction. Okay, not me. One of the things that the Summit County Alcohol, Drug Addiction, Mental Health Services Board has is a full-time psychiatric medical director. And that was the job I had, and I was succeeded by a person who's doing a better job than I did. And he is seeing that the system is working as best as it can, despite all the restraints. I mean, I wrote down 32% of Virginia state hospitals are taken by civil patients. So you got 68%, if I can do my math right, who are forensic. Well, we're jealous. In Ohio, it's like 95% forensic now. And so the state hospital is not an option. Nobody even thinks about it. But the point I'm trying to make, not very articulately, is accountability. There is no accountability to the system. In my mind, when I was in the job of being a medical director for a county board, which was the mental health authority for the county, my job was to make sure that nobody was falling through the cracks. And my job was to receive phone calls, probably before email, if somebody was worried about someone who wasn't getting what they needed. And I could then try to work on coordinating with the mental health agencies that we funded and the other systems, the local hospitals, the state hospital, and there was some sense of accountability. Now, I'm also a parent, and I know what it's like to be on the side of trying to get help for your kid. And it is incredibly frustrating when there is no one that you can call who's accountable to see that your loved one is getting what they need. And I think systems need that. And I have a bias that a psychiatrist is in the best position to be the clinical oversight. I think there are obviously administrative needs that are better met by people with other skill sets. But there's, if you're in a county or a jurisdiction where you don't know who you can call when things are not going right, you have a problem, and I think that is the case in most of the country. And so accountability is what I would say is the biggest, the lack of accountability is the biggest flaw in our systems today.
Concur. And Dr. Lewis?
Yes. I would say mostly everything that's already been said. When with deinstitutionalization, the lack of this thought that the communities were going to catch these patients who now become our homeless population, who become our veterans, who we didn't even recognize PTSD for what it was. So I think the lack of beds have now led to that, but also, like you said, the lack of ownership, the lack of accountability, and the working in silos. I mean, even being at this conference and looking at Maryland and what we have looking at us, which is we got a lot of different counties who are going to have to, stand up AOT, but how is everyone going to do it? I really think there needs to be like a federally recognized program with some ownership, some accountability. All places are unique and need to work in their unique ways, but there should be someone who's responsible for making sure that our most vulnerable are not falling through the cracks. So,
awesome. Yes. So let's stay with you, Cynthia, actually, and let's bring the next question to your end of the table first of what do you think we need to change from a systems viewpoint of the big picture?
I think what we need, again, is some accountability, some ownership. I think that we need people to be aware that, I think there's a lot of resources being thrown to crisis management, into suicide, into the acute treatment of patients, and not enough for our chronic patients. Actually suicide is most, there's an increased rate in our chronic patients more than there is in our patients who present acutely. So I do think, again, resources. When I started reaching out to the insurance companies to find out why are the person who I'm seeing 15 times, literally, in the emergency department, you can't turn them away. It's against the law. So I didn't understand why there wasn't any red flags or more concern or desire to find out why this person is failing. So I really do think that there needs to be just a level of ownership, accountability, and I think it has to come from above, and where people can't just kind of go back to their corners and be overwhelmed and think that we can't address this. It can be addressed, and it can save monies, it can pay off in dividends, and our patients deserve so much better.
Thank you. Dr. Munetz?
So the first thing I want to say is that I don't think we prioritize the most seriously mentally ill, the people who are most in need. And that's something that ought to change. It makes the most sense that the people in the greatest need ought to get the most help and ought to get to the front of the line, if you will. I think what I'd like to see change, and this is an aspiration that will be very hard to achieve because I think the insurance world and money sort of drives everything, but the way we use psychiatric hospitals is problematic. In fact, I think it's the definition of insanity, doing the same thing over and over again and getting the same result and being surprised what we do. So we used to, it's a really small world. I was in Worcester, Mass. for 3 years, shortly before you were. I was at that mental health center. I think it's called HealthLink now. and it's the Worcester Area Community Mental Health Center. We used to keep people in the hospital long enough to fully evaluate them, initiate treatment until people were really beginning to be really stable, not just, well, I didn't have a suicidal thought the last minute, so you can get out, and have the opportunity for the outpatient team or whoever was going to take over in the community to meet with the person and begin to develop the relationship or continue a relationship if it was ongoing. We don't do that anymore. We have these incredibly ultra-short hospitalizations, and then people say, well, it's not working, because they go out and they just they non-comply with treatment, and they just get sick again, and they just cycle in. And there's actually a publication recently arguing we ought to consider them futile cases and just abandon them. And I say, no, we ought to think about doing this differently. That there is a subgroup of people, and I don't think it's that large, but it looks that large, because it's a very small percentage of our very large population who if we were able to do what I just said, which is make sure we get the right diagnosis. I know Dr. Laitman's going to talk to us about this in the next session. Get the right diagnosis and provide the right treatment long enough for it to begin to really take. And then, if there's not enough time to if you can't keep them in the hospital for them to be really stable, then in Ohio, and I think around the country, we're beginning to develop these step-down units, sort of quasi-hospitals for longer-term stay, for a month or two, until people are really well enough that they'll be able to adhere, whether they're on AOT or not. Not all these people need AOT, but AOT is going to be necessary for a subset of folks. I think if we did that, we could have a much better result. And I think it's something we used to do, and then as our culture seems to do, we throw babies out with bathwater and go from one extreme to another. So instead of locking people up in state hospitals forever, we decided hospitals are inherently bad and nobody should ever go there. So, I think I made my point, but that would be my aspiration. We're going to talk about advocacy in a minute, so I'm going to give you a preview of I was thinking about my hometown, my current hometown, which is Cleveland, Ohio. We have the Cleveland Clinic, University Hospitals, Case Western Reserve, and Metro Health, which is a county mental health, a county hospital. With the exception, no, I think without exception, not one of those hospitals have inpatient psychiatry beds in the city of Cleveland, where the need is greatest. They either have no beds or they're basically in the suburbs, where people are better off and far away from where families are and all that. These are large billion-dollar or multi-million-dollar institutions, tax-exempt, nonprofit. They ought to have a responsibility for their communities, and so I think we need to start advocating for that.
Thank you. Ingrid?
Yeah, of course, I have some thoughts. You won't be surprised. So definitely more acute beds locally. So the more we can treat people locally within our communities, the better the collaboration, coordination of care, and we're really doing our patients and ourselves a huge favor with that. One of my pet peeves is the baseline discharge, which God knows what that means. It means something different to everybody. But it basically means a patient comes into the hospital, they're medicated just enough to take the edge off, and then they're discharged, often on medications that were previously tried and didn't work in the long run. By the time they show up on your doorstep in the outpatient clinic, they've already stopped the medication or they've decompensated again, which is incredibly frustrating. And then, of course, patients don't want to go back to the hospital because they didn't receive any help there. We've talked a lot about AOT, obviously. This is an AOT symposium. I wish I could say we had AOT in our community. We do not. I would love to see it as another tool in our tool chest. Off the top of my head, on my ACT team, I can think of a whole number of patients who would have really, really benefited from that. And I hope that that's something that comes to our area in the near future. So just on a day-to-day basis, I think collaborative relationships, as we've been talking about here, with all of our stakeholders. So there are a few areas in medicine that have more different entities involved that are trying to coordinate care. The courts, the criminal justice system, law enforcement, medical treatment, psychiatric treatment. Psychiatric treatment is often in separate facilities, whether they're private or state hospitals. There's a whole lot of interfaces there where making an extra phone call, sending an email, sharing information would be so valuable. Certainly better care and access to care in prisons, and advocating for larger formularies that aren't just based on maximal profit for the care providing company. It's not even the physicians anymore. It's whatever the organization is that's coming in. I wanted to talk for a moment about medications because, wow, we're going to be getting a lot of mixed messages from HHS and CMS about how psychotropic medications need to be used in our communities. So medications are clearly a large part of the solution for our seriously mentally ill. They're not always the only solution, and it needs to be coordinated with other modalities. So one of the things we can't do is medicate away social problems like hunger, social isolation, loneliness, unsafe neighborhoods. Those we need to invest some energy there. We're also in this time where we're medicalizing sort of normal mental health responses to abnormal situations. So we need to get away from just thinking that a pill is going to cure everything. It's the fastest way to solve a problem. It is not the best way to solve all problems. In terms of antipsychotics, let me make a pitch for long-acting antipsychotics. Antipsychotics in schizophrenia and true psychotic disorders, they work. They don't work for everybody. They don't work completely for everybody. There are significant side effects, but they can make a huge difference in keeping people out of the hospitals and jails and improving quality of life. By now we have preparations every 2 weeks, every 4 weeks, every 3 months, every 6-month preparation. Help patients find the one that works the best for them and that they are willing to tolerate, and keep them on it. I've seen some patients for over 20 years in our community mental health system. Patients don't just get worse, they get better. They get better when they receive the care that they deserve and need, when they stay on medications, especially LAIs, where the drug levels stay fairly consistent. We see improvements even years later. I had a great moment with one of my ACT patients. When he came to me, his name happens to be James. He came in looking like Jimi Hendrix, completely psychotic, almost nonverbal. For reasons I still don't understand, he was willing to get back on his long-acting injectable. The first time I saw him on the ACT team, he remained on the medication for the next several years. He was not hospitalized once. He was in a stable romantic relationship. He had stable housing. He was helping his mother with early dementia in her home. We were sitting in her little living room and chatting, pleasantly, and he looks at me and he smiles and he says, "I wish I would have figured this out a couple of years ago. It would have saved me a whole lot of trouble." At that point, he was in his 40s and had had his first psychotic break in his early 20s in the military. So what else do I have to say? Yes, certainly, especially for patients with anosognosia, LIAs can really be so helpful because you don't have the daily struggle of, should I take my meds? Do I need my meds? You get the shot, you don't think about it again until the next time. So one more quick thing about medications, polypharmacy, oh yikes. So again, in our system, we're very quick to add a medication. What we're not quick to do is to taper off a medication that either isn't working or is only partially effective or is not being tolerated. We medicate side effects with new medications, which cause more side effects. So again, we need to get to a much more thoughtful approach in how we're using those medicines. And that's where people in who are helping to take care of folks can really be instrumental in sharing information. What has worked previously? What didn't work? What are you observing? Because our patients aren't always the best advocates for themselves. Yeah, and so I think also when you're minimizing polypharmacy and side effects, you're also minimizing the long-term risks. There's a lot of metabolic risks. There's tardive dyskinesia, long-term things. Patients are a lot more willing to buy in when you give them a say in what they're taking and how they're willing to manage it. I have patients who had residual symptoms but chose not to increase the medicine because they found other ways to deal with those symptoms. Listening to music to drown out some of the voices, having a whole lot of creative ideas that were preferable to adding more medication. And again, just relationship building and building trust is so important, and that only happens in long-term relationships and when you show up. And when you show up when things are the worst, not when things are just going well. So I'm biased. ACT teams work. Please advocate for more ACT teams. They create connection. They help with day-to-day problem solving. They increase stabilization, not always, but for many patients. And they really encourage and normalize medication adherence. And then we really haven't had much of an opportunity to talk about substance abuse treatment, but huge piece. So again, we're going to get a lot of messages about the treatment of addictions in our community from the powers that be. We need treatment. We need access to medication-assisted treatment. The opioid epidemic is not over, and those are all things that we need to continue to advocate for.
Oh, I really wanted to give at least Mark and Cynthia a chance to talk about the advocacy. Can we do that? Quickly. All right, I'm being told very quickly. I really want to give you the opportunity to talk about how can people in the audience, knowing that it takes forever for us to get the systems changing, how can they be taking the starfish approach? I call it the starfish, one person at a time. How can people be doing what they can within the system that we have? And also, how can people start engaging more to help with the work of changing everything? Cynthia?
I can say for myself as a provider, I think if you're really passionate about something and you see something is wrong, you can't be afraid to speak up. And I think in the climate that we're in right now, and just watching people just really lose themselves and lose their values and be afraid and have all this fear, that's when a lot of bad things can happen. As a psychiatrist, I felt like I'm here at Johns Hopkins. I'm the director of our psychiatric emergency services. There's a lot I can do just being in that role. I realized there wasn't a lot I can do from the front lines, and I realized I had to start finding out, okay, who makes the decisions, who makes the laws, who do I need to get in front of? I got great advice from people that whenever you're in a room with other people, ask a question, speak up, let people know what you're concerned about. I had to start reaching out. What I didn't realize, I was going to get a lot of backlash. I started feeling like I was, that people didn't like that I was advocating for something that I thought was common sense. And I had to start writing op-eds and start, reaching out. And honestly, there's even people within my profession who did not agree with involuntary commitment and agree that, with autonomy, which of course patients have the right to make their decisions and they have the right to advocate for themselves, but I felt like I was advocating for those who couldn't advocate because of their anosognosia and their lack of insights, and I felt offended, honestly, that our system was allowing this population to just languish while others were advocating, while everyone got to go back home to their warm beds, but my patients were going back under the bridge and their families were calling me on the other line at the emergency department like, why can't you do for my patient? So I will say that, to me, Representative John Lewis, good trouble. I felt like I'm okay with getting in some good trouble because I feel like at the end of the day, my patients, I lost patients. I said, we're going to lose patients, and I just couldn't stand by. And I felt like, I don't care. I'll just get into the good trouble. And at the end of the day, thank goodness, we persevered. Maryland is now no longer three of a kind. We are now part of the 47 other states that now have AOT. And, you just got to, if you believe in something, go for it, make those connections, be respectful, but let your voice be heard, is what I would say.
Very good.
Once again, I don't have a whole lot to add. I wrote down 4 brief things around the advocacy, and I'm thinking about this more from the view of a parent than a professional, but I think it would apply across the board regardless of what your role is. One is to, if you see something that you don't understand, ask why. Because we do a lot of things because we do them this way, and if you ask why do we do it this way, you might not get a coherent explanation, because a lot of things ought to change. So ask why. Say no if someone asks you to do something unreasonable. And I do have a personal story with this, where my adult daughter was in a hospital for alcohol detox, and the hospital said she's ready to go home. Come get her. And my wife said, no, we don't have a plan yet. And that totally changed her life. She's now 16 years sober, and from that point of view, doing great. Say no. Wherever you sit in the system, if you're not happy with what's going on, ask for another opinion. It's always okay to ask for another opinion. And finally, I wrote get political. And in my career, I did it through involvement with the State Psychiatric Association. I did it with involvement with NAMI, our state level NAMI, and locally. And I didn't write it down, but the other thought that comes to my mind is be patient. So we started AOT in Summit County, Ohio, in the early '90s, and it wasn't until the 2010s that it's spreading across the state of Ohio in a dramatic way. So sometimes good things take a long time to happen, and it's hard to be patient, but be patient.
I'll put it another way. Better is better than nothing. You can't always get your perfect.
Yeah, just a couple of quick thoughts. So not just to spread doom and gloom, individual relationships are so important. So systems take a long time to change. Work with whatever interface you have. We can all do something every day. Over the last few years in practice, I participated with some CIT training for law enforcement, giving talks on suicide and how to intervene with suicidal patients. We can all do things every day to make things better. Homelessness is a big problem. Hunger, support your local food banks, your homeless shelters, volunteer. The more we know each other and listen to each other and support each other on every level, we'll have a stronger community for it. So just a closing thought. So, as a physician who's loved medicine and caring for patients for several decades, I want to close with 2 quotes. And the first one is by Hippocrates. And it's, wherever the art of medicine is loved, there is the love of humanity. And the last one is by Arthur Schopenhauer. Compassion is the basis of all morality, and we can all use and deserve a little bit more compassion and grace. Thank you.
Okay, so we do have a few minutes left for audience questions, if anybody has a question out there.
Thanks for everything you said. I loved it. So one of my son's former doctors told me that it takes 1 year to 2 years to actually hire a physician, right? It takes a long time to get someone on board. And that person has a lot of offers. So how can we, you guys are wonderful, the judges are wonderful, but how can we attract more good doctors to the field of psychiatry? It seems like psychiatry is getting dumped on a little bit right now, and I love psychiatrists, but how can we get people like you?
Everyone's reaching for the mic.
I know.
Well, I will say, there's a lot of burnout. There's a lot of working a lot of hours. Our younger generation, they're not really, they they need to be encouraged that medicine is still a good and vital thing to go into. They need to be supported with student loans. I mean, people can come out of medical school with $200,000 worth of debt. And then you go to a community, or if you want to help the community, you might not get paid as much, so they need to do better with loan repayment. I do see that there are more people in medical school wanting to go into psychiatry. We are now, a lot of us, our communities are using psychiatric nurse practitioners, and there are some states who I think are wanting clinical psychologists to start becoming prescribers. As providers, we have to be careful because the level of training and the level of expertise that's needed, we need to make it better and more incentivized for students to want to go into medical school, become psychiatrists, so that we're not, allowing others who could do well, but the training's just not up to par. So I think it's really investing in our students, making sure that they can afford to become psychiatrists, making sure that, I did loan repayment, I did the National Health Service Corps. It allowed me to go to an underserved area, but there are a lot of areas that just don't have anyone. So there's just have to be a total restructure of medicine in general. People can't go into hundreds of thousands of dollars worth of debt and then be expected that they're just going to go because they're good people. It just doesn't work like that anymore.
So before I retired, I was at a medical university, and I was hired really through funding from PEGS Foundation, one of the sponsors of this symposium, and my charge was to get more medical students interested in psychiatry. And if you attend to it, it's not difficult to get. I think our graduating class just now was about 10% of the class going into psychiatry, which is pretty good. The question is how to get them into psychiatry practice in the public sector, taking care of the most seriously ill. That's a bigger challenge, frankly, and it's gotten harder for the economic reasons that you just heard about. And so until given all the factors, until we make parity in reimbursement for physicians in public sector work, it's going to be really a challenge. So I don't want to be overly rosy, but if you expose medical students to public psychiatry when they're in training, and then residents as well throughout their training from the very beginning, from PGY1 through the 4 years of residency training, to working with the seriously mentally ill in all the different settings. There was a workshop yesterday that talked about this in El Paso, Texas. You develop enthusiasm. There's some people that really get turned on to this because it's so rewarding when you really help someone. So it's not impossible, but it takes a lot of work.
So I would definitely second what was being said about medical students. So for the last 5 years, I've been mentoring some medical students from my old medical school, which is up in just outside of Portland, Maine, and I'm happy to say that I have a 33% success rate in recruiting a budding psychiatrist. I've given some talks up there on ACT work and sort of literally what does it look like. It's incredibly rewarding work. It's incredibly gritty work. It's incredibly interesting work because no 2 days are the same. You never know what's going to happen. I always say, an ACT team is an incident waiting to happen, and they do. So I think, generating some enthusiasm and just really showing how this affects, kind of our quest for social justice as well, and for creating a better, world in all of our communities. Medical students are taking on tremendous financial burdens right now. We should be looking at, there are some free medical school programs now through certain universities. We need to be looking at those kinds of things if we want to maintain a stable workforce. And there's a lot of talk about burnout, so it's another one of my pet peeves. I hate the word. It sounds like physicians have sort of accidentally or intentionally overdosed on caring for patients. What I really see a lot more is a moral or soul injury. So the work we do, we encounter a lot of suffering on a day-to-day basis, and it rubs off on us, and it takes a toll. And sometimes people reach a point of supersaturation, and then it's important to be able to step back and to realize that you need a break also. And so I think that's a huge contributing factor. And pushing back against the medical takeover by for-profit hedge funds and corporations. Physician autonomy has become eroded. When Dr. Munetz talks about accountability, it used to be that physicians were in charge of the care of their patients, and now they're not. And I like to joke, we're 100% accountable and liable, but we don't have any of the control and autonomy anymore. So it's very frustrating, especially for those of us in medicine for whom it hasn't always been that way. So I think that those are all very real issues that are contributing to the doctors' shortage right now, and we really need to be proactive in generating enthusiasm, financial relief, and motivation for the next generation to pass the baton to.
Thank you. Do you think we have time for one more, or are we good? Okay. Could we get a round of applause for these wonderful panelists?